Good evening, everyone. My name is Franklin. I am one of the two co-founders of NordCal SCI, also known as the Northern California Spinal Cord Injury Foundation. Welcome to tonight's installment of our Virtual is the New Reality series. We have a very complex topic to discuss in spasticity and spinal cord injuries. And I am just thrilled to have someone who's really an authority in this area because she sees so many patients with spinal cord injuries that experience and suffer as a result of spasticity. We'll get to her in a second. So let me just go through a couple of housekeeping items. Number one, everyone has been muted so that we could eliminate any background distractions. If you wish to pose any questions to Dr. Shem, there will be a healthy amount of a Q&A session at the end. Her presentation is going to be about 45 minutes long. So we've reserved about 15 minutes time for your questions. So you can feed them to me through the chat feature on your screen, and I'll pose those questions to Dr. Shem at the end. As usual, these presentations are made possible through a generous grant that we received from the Reeve Foundation. So I want to acknowledge them. And then finally, we are recording this presentation as we do with all of them. And that way, everyone who has registered for tonight's presentation, should they need to step out or jump off for any reason, rest assured that we will be recording this thing and we'll send it to everyone come Monday morning. It'll be in your inbox, and that way you could share it with anyone that you wish. As a heads up, spasticity is a complex topic, so Dr. Shem has done her best to be as thorough as possible. So she's going to be covering a lot of material, which is why it's even more important to have that recording, because I have a feeling you're going to be referring to it long after tonight's session. So that's everything that I wanted to share with you. So without further ado, let me kind of jump in there and introduce Dr. Shem. Dr. Kazuko Shem joined the Physical Medicine and Rehabilitation Department in 1998 at Santa Clara Valley Medical Center in San Jose, one of the top spinal cord injury rehab hospitals in the country. Her primary interests are in spinal cord injury medicine, electrodiagnostics, general rehabilitation, and clinical research. And she's predominantly involved clinically in seeing patients in the physical medicine and rehab clinic at Santa Clara Valley Medical Center, where she performs a lot of electrodiagnostic studies. Her research focuses include community reintegration and quality of life after spinal cord injury, and electrodiagnostic medicine as it applies to neurological conditions. And I am just so happy to have Dr. Shem with us. She did one on colostomy several months ago, which was very well received. So Dr. Shem, thanks for being with us again, and it's all yours.
All right. Thank you very much for the introduction and this opportunity again to let me talk um, to people with spinal cord injury and specifically on spasticity. Before I start, actually, I wanted to give a disclaimer. I actually have nothing really to disclose other than that I do work for a county government hospital, and that I do currently have a research project that's sponsored by Department of Defense, which actually has nothing to do with spasticity treatment. We are looking at psychology, telepsychology for person with spinal cord injury, but I do not have other disclosures such as any like stocks or anything like that with any of the medications or any of the devices that I will be talking about. In terms of the outline for my talk today, just to let you know that yes, I will be trying to talk and try to describe what is spasticity, what are the consequences of spasticity, and what are the treatment options in terms of medications, injections, surgical intervention, potential surgical interventions, and other non-traditional treatment options. Okay. So this, no worries, this is going to be probably the most complicated slide that I'm going to be showing today. But this is just to let you know how complex spasticity is. And we, the people in the scientific field, probably still don't quite understand how it happens. We kind of know why it
Hey,
happens, but
Dr. Shem, real
yeah.
quick, you need to share your screen.
Oh,
Yes,
sorry.
yeah, one of the small details.
Where? I have to hover over somewhere. Uh-oh. Where did I? Oh, okay. Bum, 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 bum. Do you know where I can go to share the screen?
There
I,
should be that button at the bottom of your,
uh,
where you like with the video. Did that earlier.
uh-oh. Okay, sorry about that. Um, Yep. Oh, there. Oh, hold on. I have to somehow get in there. Okay, there, there. How's that?
Not quite.
Not
Oh, there you
there.
go. Okay.
Now there.
All
Sorry
right.
about
There you
that.
go. All right. Good
Okay,
to go.
thank you.
Keep
Okay,
going.
sorry about that. Okay, all right. So again, this is probably the most complicated slide that I'm going to show tonight. But this really on the right side really shows how complicated this can be. So we have muscle out here to the left, and then a nerve that comes out from the spinal cord to the muscle, or nerves that come out, and then the spinal cord is right above us, and the brain is literally off the screen above us here. So it's a very, very complex system of nerves that work together. And that this all gets affected. So again, we probably still don't quite understand how it happened, but to put it in a little bit more simpler way. Um, so here's a brain, and then there's a spinal cord in the middle here, and then there are two nerves, one sets of nerves, one that goes out to your muscles to make the muscles move, and then the one that comes back from your muscles and your skin to let your brain know what may be going on in your legs and your arms. So when the spinal cord injury happens in the middle here, the balance of this gets lost. And what do I mean by that is that um, on the left, you can see, it says normal. So the red is a what we call motor nerve. So the big cell part sits in the spinal cord, and this red is a little nerve there that goes out to the muscle that's out here. And then, so this is showing that there are sensory input that goes to the spinal cord. There are nerve inputs that comes from the brain that's called descending drive that kind of balances thing. And then the stimulus from the brain and through the spinal cord goes through this nerve called motor neuron that goes out to the muscle to make the muscle contract. So in able-bodied person, this is well balanced and it's well controlled. And then when you have spinal cord injury initially, the spine or spinal cord goes into quite a bit of shock. So the sensory input continues to get input into the spinal cord and up to the brain. But the descending drive, what we call descending drive or the control, kind of gets a little bit less. And then the output that goes from the spinal cord to the muscle gets also diminished. So that is why when you're injured initially within the 4 to 6 weeks, you are quite what we call flaccid or quite loose. And as you evolve in your spinal cord, your nerves kind of evolve from your spinal cord injury, in about maybe 2 to 3 months or maybe longer, the amount of sensory input that gets inputted, it kind of increases. And then the descending control gets a little bit less still compared to normal or less balanced. And then we have the muscle input to the muscles that is more spontaneous and less controlled. And that's how these spasticity happens. Okay, so when you have spasticity, we call it spasticity, and there's a specific medical definition for it. But when we call spasticity, it includes a lot of different things. So it means increases in tone or resistance when we feel your muscles and or your legs and arms. When we move your legs and arm, and we feel a lot of resistance, that's part of spasticity kind of syndrome. We check your reflexes, which is usually hyperreflexic. And then we may see what we call involuntary muscle spasms, where your muscles contracting on their own, and then what we call clonosis, where legs kind of shake a little bit, especially when we do reflexes. They are called clonosis. So those are the what we call associated findings that we see when people have spasticity. And I do want to credit where I can credit in terms of all the figures and the pictures I'm showing, graphics I'm showing today. So there used to be an organization called WeMove, which I think is not really active anymore, but this WeMove.org actually had very good slides. So I'm going to show these slides for you. But this is what we call common clinical patterns when we have patients with upper extremity spasticity. So how you can see how the arms are internally rotated or elbows flexed, wrist is flexed, maybe it's clenched. You might see a clenched fist or thumb going into the palm. So these are pretty common pattern that we see with spasticity. And spasticity actually not only happens with people with spinal cord injury, but it can happen with head injury. It can happen with patients for stroke and cerebral palsy, multiple sclerosis. So some of this graphics, it may not be seen in spinal cord patients, but sometimes same similar pattern is seen in people with like stroke. But we do see some of these patterns in people with spinal cord injury. And in the lower extremity, we also see common patterns. So what this is called equinovirus on the top is where the foot is in toeing. Some people might have big toe that kind of extends and sticks up. Some people have stiff knee or extended knee, and some people have fixed flex knee where the knee is bent. And this is very common if you're sitting in a wheelchair long term, and there's spasticity on top. So then you get what we call contractures at the knee. And then some people also have what we call adducted adducted thighs, where the legs come together. And this obviously makes it hard for people to get dressed and to do hygiene. Okay. So what are the consequences of spasticity, especially as rehab physicians we look at is it affecting your mobility or transfers? Is it affecting your hygienes and self-care? Is it causing pressure sores? I've seen quite a few pressure sores, especially like around the ankles that occur because of the spasticity, especially like the leg rubbing on the sheets of a bedding. We see contractures, which means the fixed joints. Um, does it cause pain? So spasticity in the purest definition does not cause pain. However, spasms and associated consequences of spasticity may cause pain. Some people cannot sleep because of the spasms and spasticity, and there may be effects on self-esteem, mood, or sexual function. Okay. So as rehab physicians, when we see patients with spinal cord injury and spasticity, we have to do a relatively in-depth, detailed history and physical examination, which I will go into a little bit more. And we try to quantify these findings as much as possible so that when we do intervention, we know whether we're making a positive effect or not. And then we also use team approach. Definitely, I need help of the therapist, your caregivers, maybe orthotists, to try to figure out what is the best. Intervention, and intervention is not only going to be one thing, and I'll talk about that a little bit more, but we really need a team approach. And we do at Valley Medical Center have what we call spasticity clinic, where the PT and our OT comes to our clinic once a week, and we see patients together and we put our heads together to figure out what may be the best approach. Okay. So when we start talking to you about spasticity, we'll be asking for your sleeping patterns. How do you position yourself when you're sleeping? Again, how you're transferring, or the spasticity interfering with your transfers? Do you have unsafe transfers? And how are you sitting in your chair? And then also caregiver availability, which may impact how you can do range of motion or how you can put your braces. Okay. And during our physical exam, there are certain things that we look for. Yeah. So range of motion is how well you have a range of your limbs. And for people who can walk, we will look at their walking pattern and how good the balance is or not. We will look at your braces and make sure that they're fitting well. If you do have braces, I do request that you always bring in your braces so we can check out your how well the braces are fitting. And then Ashworth scale is probably the only one objective measure that we are able to use at this time with our physical exam to measure how significant your spasticity is. So this is what we get from our physical exam when we're moving your arm or your legs to see how tight it is and how increased tone it is. So it's called Ashworth scale. And you may have heard that before when you see me or our therapist and we're kind of doing our medical jumbo. But so we use Ashworth scale. And then there are at least two scales that we could use to measure spasms. And to be honest with you, I don't use these spasm scales per se, but we can ask you how frequently is your spasm happening. Is it happening frequently throughout the day, or just a few an hour, or a lot in an hour, or how easy is it for the spasms to come on when somebody touches you or somebody do a range of motion, or you're wheeling and you're bumping on the road and then your spasms kick in. So we may be asking you for those kind of history when we talk to you. Okay. And then we go into the treatment, what we call treatment decisions after that. So do we need to treat spasticity? Not necessarily. Especially when it's mild. But when do we decide or think about treating is with the spasticity is preventing or interfering with your function or independence. If the spasticity or the spasms are causing you pain, and then depending on the treatment options, is the treatment option safe and beneficial compared to the risk? So again, we look at the severity of the problem. Most patients actually do start getting put on medications while you are in the hospital, because we do start seeing spasms when you're still in the hospital. um, and so we look at where are your spasms or spasticity. Is it localized? Is it kind of more regional? Is it one in a one arm, or is it more like a hand or elbow, or is it more generalized? For spinal cord injury patients, most patients do have what we call generalized spasticity. So below the level of injury, most patients have spasm pre-symmetrically in both limbs if you're paraplegic, or in four limbs if you're quadriplegic. And then we also again look at the cost benefit ratio or risk benefit ratio, because all the medications and interventions we do are not uh, completely harmless. So then we have to say, is the intervention in a way worth the potential risk or the cost? And then for especially with medications and injections, we need to look at side effects and limitations. And then we also want to make sure that we have good understanding of what your goals are, and are we going to meet your goals when we do start a treatment. Okay. So the overall goals we hope to gain are decreasing pain if you have pain, preventing or decreasing contractures. Although once the contracture is set, contractures means it's fixed. So fixed elbow flexion or fixed foot, that's you can't really move. Then the best we can do is try to prevent that. Actually, that would be best treatment than trying to correct it once it's fixed. And then for people who can walk, can we make it safer, better pattern? Facilitating activity daily living, like can we make you get dressed easier? Or for caregivers, can we make it easier for caregivers to even pass on the sleeve, for example? So those are the things that we look for. And can we really minimize or decrease the burden of care, and also make it easier for you to take care of yourself? And then the safety. Some people, like I do hear that people are a little thrown out of wheelchair because of spasticity. That's pretty severe and it's not that common, but still it happens. So then we kind of think about that a little bit more and maybe become more aggressive. So what are the intervention options that we have? So range of motion, this is really first and primary and has to be done all the time and throughout. So I usually recommend range of motion to be done twice a day. as you go to bed in bed, as you go to sleep in bed, and then as you wake up, but you're still in bed. That's probably the easiest position and best time to be doing range of motion. And especially when you wake up in the morning, that's when you're kind of stiffest. So a lot of people have problems with spasticity and spasms and stiffness when you wake up. So stretching before and after you get up will be best. And then therapists can work on your bed positioning, wheelchair positioning. Most patients do get splinting, like a hand splint or the AFO, the leg brace. Sometimes we can use modalities like heat or cold or medications and injections. So I have one slide on this medications. I'm not going to go into too much on details of each medications, but just try to review. So there are so-called FDA approved medications for spasticity, and then medications that we use or we hear about that could help with spasticity. So the ones that we use that are FDA approved, the first drug of choice is baclofen, which I'm sure most of you or many of you have heard. And it's a very, very good medication for people with spinal cord injury and spasticity. The main downside is sleepiness. And then for some patients, we have to either switch over to or add a second medication. And usually the second medication we use is called dantrolene. It works more in the muscles so that calcium doesn't get released in the muscle as much, so that muscles don't contract as much. So we use dantrolene as more of a supplement to the baclofen. The one downside is that we do have to get blood tests sporadically for patients who are on dantrolene. And the third medication that we frequently use is called tizanidine or Zanaflex. It works what we call centrally, and it's a newer medication. It's about 20 years old, but the main downside is again sleepiness, and it's worse than baclofen. It really makes people sleepy. So sometimes I use it for patients who have really hard time sleeping and have a lot of pain at night with spasms. Then I might just use it at night. Flexeril is usually not useful more for spasms and not really spasticity from spinal cord injury. So not many people are on that. And then benzodiazepine called Valium or diazepam. That we can use. It's a very, very old medication, which many of you know as what we call anxiolytic or anxiety medication. It is a bit addictive potentially. So we try to avoid that until we make it more like a last resort. And the medications to the right, where it says not FDA approved, but there has been some research study that shows some potential improvement. So gabapentin, Neurontin, some of you may have heard, it may help with spasticity. I think it definitely works better for nerve pain, but not probably much for spasticity because people come back and tell me, oh yeah, it worked for my nerve pain, but people on gabapentin usually don't come back and tell me they improved on with spasticity. So, but again, these are medications that have been kind of looked at or used for spasticity management. Okay. And then when usually patients again will start with range of motion, splinting, then what we call oral medications or medications we prescribe. And then we look at whether a patient could benefit from injections or from the pump. So injection we consider if you have what we call localized spasticity or high tone. And the reason is the amount of medication we can use is somewhat limited. We can't use it all over. So that's why that's a limited. And then people with spinal cord injury, where you may have more generalized spasticity, that you've tried medications and maybe injections or you cannot tolerate, then we are going to look at the pump. And I'll go into a little bit more on both injections and the pump. So there are two types of injections we can do. One's called nerve block. And we have just two nerves actually that we can use this nerve block. We actually use a medication called phenol, which is like an alcohol. And it really works well, but when we use it on a nerve that has sensation, it can cause burning pain. So we can only use it on two nerves in the body that doesn't have a lot of sensation. So one nerve is called musculocutaneous nerve, which is right underneath the armpit. And this is showing how it's done. So we go into to the nerve and inject this phenol medication that relaxes the elbow. So if you're tight on the elbow flexion, this is one medication we can use. And in the leg, there's one nerve that we can use the phenol nerve injection for, and it's called obturator nerve. And it's the nerve that goes to the muscles that clasps your legs or adducts your legs. This actually works really well if your legs kind of clasp and it's hard for you to do hygiene. So we go into the nerve right there in the groin to do a nerve block. So those are potential options, and we sometimes do this in people with spinal cord injury. And then the botulinum toxins. Okay, so what is botulinum toxin? So botulinum toxin, botulism actually is a bacteria that is in the nature, and actually if you accidentally get exposed to it, you can get paralyzed. But we use it in medication in a controlled way. And there are two types. There's both botulinum toxin A and botulinum toxin B. In the nature, there's actually botulinum toxin A to I think G or F, but we only have medication for A and B. So A, we have Botox, which you may have heard of before. We have newer medication called Xeomin and Dysport. They essentially work the same way, and my block is botulinum toxin B. And how's it work is that this is a nerve that's coming out to the muscle. And as the nerve connects to the muscle, there's a place called end plate. And that's where the botulinum toxin works so that the muscles cannot contract as much because the impulses from the nerve to the muscle gets blocked by this medication. So it really works well. And it's actually FDA approved, especially for Botox. It's FDA approved for like strabismus, like ticks in your face that may happen, cervical dystonia, and for spasticity, it's approved for upper extremity and lower extremity. It's also used for cosmetics, so a lot of people know that. Know Botox from that a little bit more. That's wrinkles, and then it's also used for migraine headaches and neurogenic bladder or spastic bladder that may be caused by spinal cord injury. So some of you may be getting these Botox into your bladder for with our Dr. Elliott, and not necessarily for your limbs. But we have to be really careful and make sure that if you're getting both, you have to kind of time it correctly. And we can only inject every 3 months at the soonest. And then also sometimes we can use it for people who are drooling or grinding teeth or sweating in the hand. And botulinum toxin B, which we don't usually use, but this comes in liquid. And by the way, we have a lot of vaccine and free, and how the vaccinations need to be frozen and all that. The Botox actually needs to be frozen too, but not too bad, like 4 degrees, like a freezer, a usual freezer. And we actually make it up, reconstitute it when we're ready to use the medication. Whereas this medication called botulinum toxin B, Myoblock, it comes in liquid form. So we just put it up and then inject. But this kind of fell out of favor. So not many people are using botulinum toxin B. But if some people are resistant to botulinum toxin A, then sometimes we'll use the other form. The contraindications are people who have certain conditions, like droopy eyes, then we don't want to use this medication. Okay. Side effects, so it's not that much, but people can bleed at the site of injections. People might feel fatigue or flu-like symptoms for a couple of days. Potentially unwanted weakness, but usually we don't see that that frequently. And there's a black box, what we call black box warning, that in the higher dose, especially in like children, it could cause swallowing problems. But we haven't had these problems. And long term, if you do a lot of these injections, sometimes what we call antibodies form, so that the medication stops working after like years of using this medication. Okay, so that's what I just went over that. So that's botulinum toxin or Botox. And after you taking medications and maybe try Botox, you still are struggling with your spasticity management. The next potential option is the baclofen pump. Uh, It's called intrathecal baclofen pump. And so the baclofen, the medication is the same medication as you would be taking by mouth, but we don't need a high concentration. So we can avoid the side effect. We can increase the dose without making you too sedated. And then it may work better because we can get the baclofen into your spinal cord in a much, much higher dose. Okay. Unfortunately, because of the gravity, baclofen usually only works really well for the legs. If somebody, for whatever reason, have more arm spasticity than the leg spasticity, then unfortunately it may not work as well. So that's the pump you see here. It's like a ice hockey puck size, and we actually have a sample here. Is that if you want to take a look, we can show you what it looks like. And there's a catheter that actually goes up into your essentially along your spinal cord, and then we refill through the skin, and then we tell the pump how fast to run at. So we have about, I think, 20 to 30 patients currently with pump. Not everyone's spinal cord injured. We have patients with other conditions that also have pumps, but you need to refill every, sometimes as frequently as every 1 month to every 6 months, and then the battery does run out of the pump, internal pump. So internally, so the pump does need to be replaced every 5 to 7 years. Okay. Um, and then if we've done the pump and the medications and conservative measures, um, we start thinking about, well, is there some other surgeries that you might need? Okay. So if the patients have what we call, again, contractures or fixed joints, then surgery may be needed. And this is a slide that I got from WeMove, but this lists potential surgeries that could happen. However, most of this are, except for the one here with the tendon release, all these are not really standard of care or has not really shown to be effective. As you see here, it's not very encouraging in terms of the efficacy of the surgical intervention. The one that we do here, and we have a very good orthopedic surgeon right now who does the tendon release surgery, is the tendon release. So if somebody's heel cords is very tight and we can't move the foot at all, then sometimes we will have the surgeon to release that so the ankle gets released and then straightened out. So that is a surgery. And some people also have maybe tightness in the hands where the fingers are really tight and we can't even clean the fists or the elbows, then we might do surgery. And we'll talk a little bit more on that. So for spinal cord injury patient, the other consideration is that it may not be just because it's spasticity that's causing you a problem. So, for example, for the shoulder, you might have tightness just because it's been positioned in that way, and there's a muscle imbalance, or maybe there's a tendonitis problem with the rotator cuff tendonitis, or maybe there's arthritis. For shoulder, if there is um, a rotator cuff problem, then maybe surgery is indicated. Now, sometimes we can do both botulinum toxin or Botox injection to the pec muscle to loosen the shoulders. And then on the elbow, as I was mentioning, some patients have really, really fixed elbow because bicep works a little bit stronger and it's spared more than the triceps. So some patients really get real tight in the elbow. So we'll try splinting, but if the contracture is really significant and it's really interfering with the function, it's possible to do surgery. But I can let you know that I haven't had that many patients who do elbow flexion release contractures. We only do it when it's so bent that you can't even clean the inside of the elbow. Okay. And then in the forearm, so patients can get what we call pronated hand, where the hand is down, and then there are cases where actually called supinated, like soup, where the hand is up. So in general, we think that hand that could be going down is more functional, and the hand that's more up is not as functional. So if there is spasticity and then contractures, we might consider doing hand surgery to position the hand better. Okay. And the wrist, usually again, we wouldn't do a lot of surgeries for this unless it's so tight that we have hard time with hygiene in the wrist or in the fingers. But before that happens, we really, really try our best to do splinting medications and also botulinum toxin to see if we can loosen your fingers and the wrist. Okay. And again, fingers, depending on your spinal cord injury, some people have certain patterns of finger tightness. And we can refer people to our hand surgeon. We now have very good hand surgeon. We have really wonderful surgeons right now who really care about people with spinal cord injury. So we have hand surgeon who can help with the fingers being released or put in more functional um, position. Okay. All right. So, what are some other options that are not like medical? So, standing frame. This is, I think, it's a glider or evolve that we have in our gym, and I think I got this just off the Google. But there are many, many different standing frame. Unfortunately, what's challenging is that some insurance doesn't cover standing frame. That's probably the most challenging thing about this, and it could be very expensive. But we try our best to try to justify for a standing frame. And once the COVID situation improves, we do have open gym program. We barely got started on that last year, that where we can have an open gym where people potentially can come and use our exercise machine, including the standing frame and like FES cycle. But standing frame really does help, and recommend using about 1 hour a day, either 30 minutes twice a day or 1 hour a day. We don't recommend people use it more than that because you start to have more like a leg swelling. So, but 1 hour a day will give you a pretty good stretch, but making sure that we stand really straight up when we're using standing frame. Okay. Other things, acupuncture I've tried. I don't usually try e-stim or magnetic stim. It's been mentioned as a treatment, but it's pretty not standard. Hippotherapy, I have few patients who are interested that went down to, I think Gilroy or Mountain View has a hippotherapy place. So hippotherapy, the horse riding treatment. So that may be, could give it a try. Hyperbaric oxygen, our O'Connor Hospital and our St. Louis Hospital now have hyperbaric oxygen treatments, but usually I don't use that for spasticity. And then vibration, there's not enough scientific evidence yet, but it's been kind of a hot topic in the field of rehab to use vibration for vibrating plate for different reasons. So um, this got this from Amazon, but this big one, the standing one, is like a $10,000, and then the one that are looking like more like a little foot plates, they're like $100. But again, it hasn't been really shown, and I don't have patients who are actually using it actively to help with spasticity. So there's probably need to be more research. And I understand, Franklin, I kind of getting short on time, but I think I have enough time to talk about the
You
marijuana.
do, you do.
I'm sure a lot of people are curious about this. So the next couple slides, it's actually very, very just history. Um, so I'm going to really go over really quickly. But the whole point about my showing this history about medical marijuana or marijuana is the problem with the legalization, and why scientifically, medically, why it's hard for us to let you know much about medical marijuana, and the evidence behind it. Okay, so as you know, California has legalized initially legalized like a medical marijuana use, and then now recently recreational use. Federally, marijuana is still quite completely illegal. So that really makes it hard for us to study marijuana use in terms of, for spasticity management or for nerve pain. But let me, um, I never actually, believe it or not, 20 years ago when I graduated from med school and residency, nobody talked about how the medical marijuana works, in terms of a for our disabled population. And I actually just asked my resident here too, and he also never got anything, any lecture about medical marijuana in med school. So that actually has something to do with, because it's so federally still considered illegal. But what we do know about is that in our body, there are two receptors called CB1 and CB2, that the marijuana works on, or cannabis works on. So CB1 is more in the what we call nervous system. So that's where probably a lot of the positive effect could happen. And CB2 is not in the nervous system as much as you can see here, but it could affect the appetite and the pain, the mood, and the memory. Okay. And cannabis actually, I had to read up on it a little bit myself, but there's like 400 chemicals that's in cannabis, and there's 60 different types of cannabinoid chemicals that's in cannabis. But the two main cannabis chemicals that is of importance here is THC and cannabidiol. So THC binds preferences to the CB1 receptor, which has the higher psychoactive effects and abuse potential. Whereas the CBD, where we hear about CBD oil and CBDs are being sold in like CVS and pharmacy these days, it has limited psychoactive effects, but it may work to prevent seizures, it might help with anxiety, psychotic episodes, or nausea. And it may have sedative effects. So, the one research study that I could find on cannabis in spinal cord injury came out of Colorado in 2018, and all it looked at was who was using cannabis. So, among the people who they looked at, 67% used before spinal cord, and 53% were using after spinal cord. And I know personally, I've actually asked my patients, and I think majority, more than half of my patients, are using some marijuana in some form. And the reason for using the Colorado study was 70% was to reduce for spasticity, 63% was recreational. So I'm sure some people are using for more than one reason, and then for sleep. In that study, the most common method that was used is smoking. And at the minimum, what I can tell you is, if you're going to use cannabis, please avoid smoking, because it's really not good for your lungs. So most of my patients, I think, when I ask, majority of patients usually tell me they're using different form than smoking, but a few patients do tell me they are smoking. And then one research study, this is like the only one I could find, that THC was used for spasticity management, comes out of Switzerland, of course, not in the US. And it's back in 2007. So this was a really nice control study where they used the medication form of the THC, which is called dronabinol or marinol. And by the way, those are available here in the US. um, and when used for at least for 15, 20 milligrams of the medication, it did have a positive effect on spasticity, but for whatever reason, patients dropped out because there was too much pain or psychological effect. So again, the cannabis is there is a THC that, medication form called, usually what the one we use here is Marinol. So it's usually used for patients with like cancer, who has nausea and pain. So it's been used a lot in our clinic here. Currently, I don't think I have anybody who's taking this medication for the purpose of spasticity management. I don't know if people are out there in the community that may be using this potentially for spasticity management, but it's not. I guess FDA approved for that. So the side effects are tachycardia, that's heart racing, drop in blood pressure, which people with spinal cord injury already have. So that's a concern. Hot flashes, sweating, runny nose, loose stools, hiccups, and anorexia, loss of appetite, and other feelings of being subdued, absent-mindedness, or taking risky behavior. So obviously, as I was talking about the risk-benefit ratio of anything we do, this may be somewhat too risky. Okay. And in terms of pharmacology, just if you're curious, of course, if you inhale, it will get in much faster in minutes. But whereas if you eat, some people use like brownies, from what I hear, it could take longer for it to affect. But it has a relatively rapid peak in the blood, and it peaks in the brain a little bit longer, so 5 to 7 days. The peak effect lasts for about 7 days, and for it to completely eliminate, it takes about 30 days. And again, sometimes people have relaxation or euphoria, being happy from the medication, but there's lots of also downsides like confusion, decreased memory, or hallucination. So I do have few people who are trying to go back to work or go to school, and they've tried either medical marijuana, or other forms of cannabis. And most of my patients, I think, who are working or going back to school are telling me like it's not working out for them. Okay, so I'm sorry I don't have too much on cannabis again, because we can't study it legally, despite it being approved in California. But there is really not much out there in terms of literature and evidence-based use for of marijuana. Okay. So I think actually I'm quite almost on time, right, Franklin?
You are indeed. You are indeed. Thank you.
So this is my team, actually my research team. For those of you who may be participating in my research project or maybe interested, this is my rehab research team. So maybe I may have seen them or talked to them once in a while there and here. And there you see Dr. McKenna and all that. So any questions, or I
Indeed.
guess
Actually, we have a
yeah.
number of questions.
Okay.
And if you can go ahead and stop sharing your screen, Dr. Shem, that'll be great.
Uh,
The
stop,
first
stop share.
question
Okay.
is, what is the relationship between standing frame and how it affects control or treatment of spasticity?
Oh, so standing frame is essentially range of motion. So it's giving you a good sustained stretch. So that could be from the standing frame, or actually people can also use bracing, which you can use, longer term during the day. So what we're looking for is how can we give you sustained stretch? I don't know if that answers the question, but it's just that for standing frame, it's not practical, or it may not be safe for people to do it more than 1 hour at a time.
Okay. Next question.
Hmm.
How, where does the body decide, or how is it determined that the spasticity affects or goes or affects a certain part of the body? Why does it move around so much? What determines that?
Ooh, that's an interesting question. For most people, from what I'm seeing, most people have like a pattern. So either you get always affected in your legs, or always affected in most more in the arms. Some people have it in abdomen, where the abdomen just tightens up. So that's also spasticity or spasms. Um, I don't usually hear that it goes to like different parts of the body, but it definitely happens below the level of injury. It does not happen above the level of injury.
For the most severe type of spasticity, what is the go-to intervention?
Um, Depends on the each person again. But I think for us anyway, it will be the pump. The surgery is again is for contracted patients who can't even move their limbs. I wouldn't consider that like a severe spasticity per se. But if you're talking about in the general, what is the spasticity management? So coming down again from range of motion, stretching, medications, maybe injections, and then at the end probably is the pump.
Okay. And for sort of muscular spasticity,
hmm
same thing.
Um, Yeah, so the muscle spasms that happens like above the level of injuries, because some people do have more of a spasms. I don't know if the pump is the answer for that. In general, we consider pump as treating spasticity, which is kind of similar to spasms, which is again involuntary contractions of the muscles. But I don't know if that helps that much with a pump. I think it should, but it happens so simultaneously. So sometimes we can't really separate out. We again look at it more of a big syndrome of spasticity and spasms, and they kind of get intermingled. So you have severe case of that, and then I think the most significant advanced treatment would be probably pump for us.
Okay. All right. We have a specific question. A 23-year-old with a C5-6 incomplete since March 2019. He has no visual movement in legs. He has abnormal spasms, and they found out a few months ago that he has a Seronex.
Oh, syrinx.
Sorry.
Yeah.
He's not on any oral spasm meds because he's maxed out on baclofen, dantrolene, and tisendenine with
hmm
absolutely no results. And he was weaned off of them, has been off since May of 2020. He went through a baclofen pump trial with a very high dose and it worked. He prefers not to have an electric device implanted. Is there any other option?
Mm. Unfortunately, probably not. Again, then are you, start thinking about medical marijuana, acupuncture, but uh, the pump seems to be the most reliable medical intervention that we have. And if it's working for you, I think that's wonderful because for some patients, the pump, for whatever reason, doesn't work. Um, so sorry, I'm not sure if I have a good answer for that, but
Okay. All right.
I would definitely not recommend rhizotomy. That was one of the surgical, old time surgery intervention that's been done in the past, and I think it's rarely being done. It literally you cut the spinal cord, but it's got its own problems, and I don't think that's going to be a solution for most people.
Okay. Next question. How can you tell the difference between a muscle that has shortened due to lack of range of motion that with work can be stretched back out versus spasticity?
Um, so sometimes we will do those nerve blocks or motor point blocks or Botox injection, and if we can move it, then we know that it's just shortened, and then there's a potential for us to stretch it. If we can't do that, and then we'll say no, it's really not stretchable. When we say contractures are fixed, it's really fixed. We really can barely move a few degrees of that ankle, if we're talking about ankle or the knee. It's so fixed that we just can't move it. Then we kind of know the joint, the capsule, the ligaments, and everything, the muscles are shortened. Whereas if we do like anesthetize you, the other thing is like see what you do when you're sleeping. Look at your patient when you're sleeping. If they're completely relaxed and you can actually move things or stretch things, then it's probably not contracted. The other way that we wouldn't usually do this, but let's say you're completely anesthetized for some reason, like you're having a surgery and you are under general anesthesia. And if we can move your limbs relatively flexible and we can stretch you out, then it's not fixed.
Okay. Next question. I'm 7 months from my injury. Does spasticity tend to worsen over time or can it get better without intervention?
So the timeline on this is we have patients go into spinal shock within the first 4 to 6 weeks. In about 2 to 3 months, we start seeing little spasms in here and there. It usually tends to increase in about 6 months to maybe up to a year. Then things usually stabilize, unless, for example, you have bladder infections, your constipation, you break your leg, you have pressure sores, then your spasticity definitely can increase, like a temporarily. Okay, but in general, overall, the spasticity, the severity should not change that much, and unfortunately, it does not get better on its own
Okay, and
unless
this
you're having a recovery.
right, and this person says that his seems to be getting worse, and he's currently on a baclofen with without much change of
Yeah,
his dosage is 10 milligrams 4 times a day.
that's a low
Uh,
dose.
that's a
That's
low dose.
still, yeah, that's a medium low dose. Yeah, so 7 month is where maybe potentially it could stay a little bit there, or it can continue to get worse. I would wait probably about till a year to really know what you may be like long term. But after that, it really shouldn't get too much worse. If it gets really, really, really too much worse, then we really have to look about other things like the syrinx, as somebody was mentioning. Syrinx can cause spasticity to get worse. But in general, cold weather. So right now it's really bad. Patients are coming in and telling me, my spasticity is worse. So cold weather, rainy weather, and anything that the body thinks is noxious. So again, bladder infections, constipations, pressure sores, ingrown toenails, you name it, anything that your body would say, "Oh, I'm in pain," your spasticity is going to get worse.
I know this the dose varies from one person to
Mhm.
another, but what's kind of like the typical dose that you have found across the patients that you see
I'm assuming on the
for
baclofen.
baclofen?
Yeah. So the maximum dose is 20 milligrams 4 times a day, or 80 milligrams total. Most spinal cord injury patients, especially if you already have moderate to severe level of spasticity, you usually need a max dose. I have do go up a little bit above the FDA approved dose to about 120 milligrams. That's the maximums I would go. But if you're 10 milligrams, 20 milligrams, even 40 milligrams, that may not be enough.
And then is there a difference between the oral versus the pump version of
Mhm.
baclofen?
Um, so it's the same chemical, it's the same medication, but the baclofen that you take by mouth is obviously the tablets, and then by the time it goes into the brain and the spinal cord, you need to take a lot by mouth for it to be effective. Whereas on the pump, because it's going directly into the spinal cord, it's like 1,000. I think I had the number. 60 milligrams equal to some micrograms, like a hundredth of dosing that's needed for the spinal cord. So the dose is definitely much, 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 much lower when we're using the pump, but
So
it's
how do
more
you
effective. Yeah.
right? How do you determine who should get a pump versus continue on with oral?
So we usually do try to give medications as much as possible, make sure we're doing everything possible in terms of your positioning and stretching and all that. But if still that's not effective, then we do a trial. So we actually did a trial this week, but we give what we call bolus dose into your spine, the baclofen, and then within a couple hours we know whether it's effective or not, and then that's how we determine if somebody's appropriate for a pump. But up to that point, we do a lot of things because pump, the risk obviously is a little bit higher in terms of the maintenance. So you have to come in for refills, and pump, can have problems like infections and other things. It can get kinked and unhooked. It can stall. It can have a lot of issues. So my usual guidelines and rules for our clinic is that you also have to live within certain amount of distance from us, like within a county, like less than an hour. So that if we say, you know what, there's a problem with the pump, or we think there's a problem with the pump, we need you to be able to come in. We need you to be able to come in.
Right. And then how involved is that actual surgery to install a pump?
It's not involved that much. It's actually a day surgery, so most people actually go home. So there's a little cut. So the pump is about this big, like a hockey, look, literally hockey puck size. So there's a cut that was made by the neurosurgeon. They put the pump in, and then they thread the catheter. So there you only have two cuts, one in the front, and then on your abdomen for the pump, and then one in the back to make sure the catheter is in the right place, and then you go home the same day. So the surgery itself, especially when it comes to neurosurgery perspective, this is probably like the most minor surgery that they would usually do.
Okay.
Yeah.
For those people that don't have the benefit of a caregiver to provide range of motion, what do you typically suggest?
Oh, there are, well, yeah, so the standing frame will be difficult potentially. Some people can get up on standing frame, so that's a possibility. Bracing, if you can get bracing on, that may be a possibility. There are stretch. Um, um,
TheraBand?
because
Or,
yeah, therabands and other things that the therapist actually can give you to help with the stretching. And I think our therapists are really good with that. But if you like a review of that, and then we will refer you back to therapy so that we can try review and kind of problem solve what can we
right.
do in terms of stretching for you.
Okay. Next question from a T2 complete from 3 years ago. Initially didn't have much spasm, now has very bad spasms when she wakes up in the morning or goes over bumpy roads. Is there a
Mm.
correlation that increased spasms could mean a sign of trying to reconnect? And could it be a good thing?
Um, Unfortunately, probably not, because as I showed in the first few slides, it's a balance of how the impulses are going up and down from your brain to your spinal cord to control things. So spasticity is that the things are so hyperactive on the muscle side, and messages are being sent, and the down control is missing because of your spinal cord injury. So that when you have spasticity, unfortunately, or spasms that you're not controlling, it's actually not a great sign, because it means that the nerves are not talking in the right way in the balanced manner.
Okay. If spasms are not causing pain or any issues with ADLs or mobility, is it best to not medicate or do any other interventions?
So it's best for a professional like us to evaluate to make sure that there won't be like long-term consequence, but it's a personal choice. So there are quite a few patients who may have a little spasms here and there that's really not interfering with your functions, or we're not concerned about long-term effects like contractures or safety. Then yes, if you don't need medications, you don't need medication. You don't have to take medication. And the baclofen, the spasticity management, is really a choice. Unlike like blood infections or pneumonia, you know that you have to treat that with antibiotics or you're going
Right.
to be really, really serious. So, but the spasticity is not like that.
Okay. Next question. You mentioned Botox in the pec muscles. Would this help with shoulder spasms and pain?
Potentially, especially if the pec muscle is pulling your shoulder in. But we really need to really take a look. And now some people can have what we call just trigger points, which is nothing to do with spasticity per se, but above the level of injury, the muscles just tighten up. So sometimes we can do injection. The shoulder gets really, really complex because it could be spasticity, but so many people use your arms and your shoulders for your wheelchair mobility, your transfers. A lot of people have shoulder pain, or there may be issues with like a pinched nerve. So it does get a little bit more complex. So there may be other things that we want to look at, and then try to figure out what is the cause. And then sometimes you may have multiple reasons. You may have spasticity, you may have rotator cuff tendonitis, you may have arthritis, you may have muscle pain. Then we try to address each of that.
Okay. Next question. Does clonus make muscles tighter or spasticity more pronounced?
No, it's clonosis is more like just it's just muscles. It doesn't do much of either. Not really. Yeah.
Next question. I have a condition called myositis ossificans,
Hmm.
similar to HO,
Yes.
in my right quadricep. Since it formed about a year ago, spasticity in that leg, particularly in the former clonus, has gotten significantly worse. Do you know
Yeah.
if that spasticity generally improves once the ossification either reabsorbs or is surgically
Yeah.
removed?
So The myositis ossificans or any other conditions that inflames things, yes, if that can be controlled or calmed down, then hopefully, like a broken leg is another example, then yes, the spasticity should improve. So I know somebody asked about like spasticity ever improves. So in general, pathophysiologically, it doesn't improve per se from a spinal cord injury, but let's say if there's something that's causing it to get bad, and you take away that reason, like the myositis of the scan or broken leg gets treated or calms down, then yes, I think there's a potential that it could improve.
So, how does spasticity get better over time? This is a question that was asked, and I
Mhm.
myself experienced it when I first got injured. My spasticity was, not severe, but quite significant. And then just over the years, it just has gotten better and better and better and better to the point that it's so minimal now. So, how does that happen?
I don't know. That's actually rare. Most patients continue to have spasticity in general. It's pretty rare to hear that it's gotten better. Now, a lot of people are living longer. So maybe there are things that happen as we age, people age. Maybe something happened to the nerves. But unfortunately, it's relatively rare to hear that spasticity gotten better after, like, let's say 10 years or 20 years after spinal cord injury.
Okay. Next question from a T4 T12 incomplete. My spasticity episodes does affect above level of injury. Is there any exercise I can do in PT to?
Above the level of injury?
Yes.
So spasticity by definition is all below the level of injury. So if something's happening above the level of injury, that's not spasticity. It's maybe something else. It could be simple muscle spasms. That's not caused by the spinal cord injury per se. So the question was, how do we treat it? Or
Is there any exercise I can do in PT to reduce that?
yeah, so if people have muscle tightness, it's still like stretching and positioning, making sure that you're in a position so that your muscles are not, tightening up. So there are, yes. So I definitely recommend that if you haven't had therapies in a while, and you have spasms or spasticity, then probably a review session will be worth it.
Okay. Next question. You say that you would begin to see spasms in a patient within 4 to 6 weeks post-injury. This person saw it within a few days. Why would their spasticity sort of set on so quickly?
Hmm, that's a very unusual situation because most people are in so-called spinal cord shock, and that lasts usually 2 to 3 weeks. Maybe the injury, the spinal cord injury itself, was a little bit different than what we consider like typical, but I'm not sure if I have a good explanation for that.
Okay. Next question. Would chronically increased sympathetic nervous activity um, impact spasticity amounts, such as higher BP, self?
Mm, Probably not. I wonder if it just goes in hand. So it's more like chicken and egg almost kind of question, I think, that which came first? Maybe the spasticity and your muscles tightening up and you have pain and then your blood pressure goes up. So I don't know. I think that one, I'm not sure how that's going to be related in a way or in terms of cause and effect. It may be reverse situation there.
So could spasticity cause an increase or decrease in blood pressure, or no?
Um,
Typically, no. It's not
I would
related.
I would say increased spasticity probably would increase potentially your blood pressure because it's tightening things up. So I can imagine that blood pressure can go up. And the other thing is, this is where it gets a little tricky, is that if you have spasticity, so that means maybe you have a bladder infection or something that's causing noxious stimuli, which may in itself bring your sympathetic activity to increase. So the physiology on this is kind of similar and same. So you may be having like two things presenting because there's something happening that causes both things to like act up.
Okay. All right, next question. How would you recommend one try to wean off baclofen? Any cautions? Obviously, in coordination consultation with your physician, right? But what
Yeah.
else?
So in general, what I usually tell people is that you can wean down on most medications 25% at a time. 25 to 30% at a time. So let's say if you're taking 10 milligrams of baclofen 4 times a day, I'll say do 3 times a day for a week, twice a day for a week, once a day for a week, and then you should be able to, but just gradually do that. So the baclofen, just to so people know that if you are on high dose of baclofen, especially oral medication, if you suddenly stop it, it's not a good idea. Some people can have what we call withdrawal seizures. So if you're on any medication in a good dose, I really caution you to do it very carefully and under physician consultation. But anytime you want to wean things down, usually if you do about 25%, 30% at a time, um, then your body also doesn't feel it as much. Of the lack of that medication is more tolerable, whether it's pain medication or spasticity medication or any other medications.
Okay. This next question is from a therapist. She's asking, is there a time period for which you hold off prescribing baclofen after an acute injury? She had a patient who's hesitating taking baclofen because they're fearful it would affect their motor recovery by slowing the nerve impulse. What are your thoughts on this?
So I'm not sure if I should call it a myth, but I haven't seen, I hear this a lot, but I haven't seen any evidence one way or the other in a way. And for sure, I haven't seen any evidence that said this slows recovery of person's neurological recovery. And I don't know if there's any chemical base to this or pharmacological basis to this. And unfortunately, I do hear this. But I think what is important, or what we should be telling our patients, is that spasticity could interfere with your recovery in terms of your function, especially when it's worse. So it's better to treat that and then have you function better. And your nerves, your spinal cord injury nerves will recover at its kind of way at its own pace, and naturally that it should. So I don't think, and if we think that the baclofen really would interfere significantly or even substantially or even minorly your recovery, I don't think as physicians we would be encouraging or prescribing medication that will interfere with your neurological recovery.
Okay. Are spasms more common in a complete or an incomplete from your experience?
Um, That's a very good question. Sometimes incomplete, but sometimes incomplete patients, like a bronze core patient, because it's so impartial. So sometimes it just get more jumbled, and sometimes we see a lot more in even in incomplete patients. But in general, if you are recovering more and very, very incomplete, I think you don't see as much compared to somebody who's very, very complete.
Okay. Um, if you could just one more favor, give us again the max dose of baclofen by pump and orally. This is another question that's been asked.
Okay. So orally FDA approved dose for baclofen is 80 milligrams total a day. And usually it's given in 3 times a day or 4-time dosing. The pump, it really depends on each person. But in one day, it's most people, the max that we usually keep patients at is 1,000 micrograms
Okay,
versus 80 milligrams by mouth versus 1,000 micrograms. So it's kind of the max that we kind of go up to.
right. And let me emphasize, please do not change your dose on your own. Consult your
Yes, please.
physician. Um, we have a question from someone who uses FES bike. Is
Mhm.
that a contributor to increase in spasticity?
Um, Probably not. That's kind of a tricky. So if you're in a way ranging with your FA cycle, okay, that should help. So I believe when we try to justify you to get FA cycle, I think that's part of it is spasticity management. However, having said that, we do use the stimulators, and then unknowingly, because you're not feeling, if you do so much of a cycle, you can have like micro damages of your muscles, for example. Then, it may come back as more increased plasticity. So I think this is where you really need physical therapists to monitor how you use your FES cycle and see what really the speed or how long or what rate or how strength. You really need monitoring to make sure that you're getting the benefits. So I'd hope that it decreases spasticity, but I can also theoretically imagine that it could actually worsen spasticity depending on how aggressively you use your FES cycle.
Okay, so how often should you use your FES spike, would you say, without
Um,
compromising or contributing to an increase in spasticity?
Um, so I believe I think it's similar to the standing frame. Like you can use once a day, but I wouldn't use it for like hours, at a time.
Right. Okay.
Whatever the physical therapist you use gives you the guidance.
Okay.
But definitely I wouldn't do it for a very, very long time because if you can imagine if you're an able-bodied person and you're cycling for let's say 2 hours or 3 hours like an athlete, right? You'd be hurting.
Okay.
So you probably don't want to be doing that.
Okay. Dr. Shem, you may not know this, but we have people all across the country that have tuned
Mhm.
in tonight. So we have a
Ah,
question from someone who wants to know if you share your data with other facilities throughout the country, or
data as in like any kind of data.
and
So in terms of research, yes, of course. We do participate in the national database, the model systems follow-up. So we definitely do kind of share data in that way. They're all de-identified, but we definitely participate nationally, or we have been participating nationally for, I think, 40, almost 50 years now. So yes, and then any research projects that we do that we can publish, they do get shared in that way,
okay,
and any conferences and presentations.
very good. Okay, that's it, folks. Thank you so much for all your questions. And Dr. Shem, I can always tell when a topic is very captivating by the number of questions that we get asked. So this was a topic that I knew was going to be resonating with a lot of people because I hear and read
Yeah.
about people's struggles with spasticity. So I know everyone, Dr. Shem gave you a lot of information, but she really wanted to make sure that you understood what sort of the cause and the contributor is to spasticity so that you have a better understanding of how your body functions and then talk about some of the medical interventions that are available. So I hope you all benefited from it. But if she overwhelmed you with too much
Mhm.
information, like I said, this meeting was recorded, purely for that benefit, so that when you get the recording on Monday, you can watch the entire presentation and make sure if you missed anything, you'll be able to catch it. Thank you again, Dr. Shem.
All
You're a
right.
wealth of information as always. Thank you, everyone, for your
You're
time.
welcome.
Have a good night and
Yeah.
a good weekend too.
Happy holidays and stay safe.
Thank you, Dr. Shem. Good night,
All right.
everyone.
All right.
Bye bye.